All right, can you hear me? Good. Okay. All right, so like she said, I'm going to talk about antipsychotic use in the inpatient setting. First off, have no financial disclosures relevant to the presentation today. Our objectives for the presentation: first, recall mechanism of action, adverse effects, and drug interactions of our formulary antipsychotics here at Erlanger. Evaluate prescribing patterns of antipsychotics, and formulate a plan to reduce the potential harm that can be caused by antipsychotics. And finally, we will compare antipsychotics and select an agent for the treatment of acute agitation. So again, the first part of the presentation, a little bit about the pharmacology, indications for antipsychotics, drug interactions. So antipsychotics in general affect a variety of receptors in the body: the alpha-1 adrenergic receptor, serotonin 2A receptor, muscarinic receptor, the dopamine type 2 receptor, and the histamine type 1 receptor. Their efficacy for most indications, especially the psychiatric disorders, is a function of their antagonism at the dopamine 2 receptor. And blocking some of the other receptors mediates unintended adverse effects. So alpha-1 blockade, most antipsychotics block this as well. They can lead to hypotension, vasodilation, and orthostasis. Blockade at the dopamine 2 receptor, again, is what we're targeting with the drugs, but it's also responsible for the extrapyramidal side effects, which we'll discuss in an upcoming slide, as well as hyperprolactinemia. The lack of dopamine leads to a negative feedback at the hypothalamus, which stimulates the pituitary gland to produce excess prolactin, which can eventually lead to infertility and decreased bone mineral density. Activity at the muscarinic receptor causes our anticholinergic effects, such as impaired cognition, xerostomia, and tachycardia. Weight gain and dizziness, common side effect of the antipsychotics, comes from their blockade of the histamine receptor. And finally, while activity at the dopamine receptor, like we said, is responsible for the extrapyramidal side effects, the antagonism at the serotonin 2A receptor actually kind of counteracts this and reduces the risk of extrapyramidal effects. The receptor has some kind of association with schizophrenia as well, but is not yet fully understood. So when you think of antipsychotics, typically think of treating these FDA-approved, more psychiatric disorders: bipolar, schizoaffective disorder, schizophrenia, or even adjunct treatment of depression. But not each antipsychotic has an indication for all four of these. In addition to the FDA-approved indications, several off-label uses for antipsychotics: ADHD, insomnia, dementia, psychosis, Tourette's, even hiccups. Our formulary here at Erlanger, we have a few of the first generations, so fluphenazine, haloperidol, perfenazine, and thiothixine. And we have most of the second generation antipsychotics, so aripiprazole, clozapine, lurasidone, all the way to ziprasidone. In comparing the atypicals, which are most commonly used, the first generation or typical antipsychotics are pretty uniform in their adverse effect profile, so I'm just going to talk about comparing individual atypical or second generation agents. The first being aripiprazole. It's a newer second generation antipsychotic, and it's found to be the least sedating of the second generations. The remainder are pretty equally sedating. Aripiprazole also has the highest risk of orthostatic hypotension compared to the other drugs in the class, so may not be a good choice for an elderly patient. The risk of extrapyramidal side effects appears to be greatest with lurasidone. Otherwise, lurasidone is pretty mild, as you can see in the table, so pretty much just sedation and the extrapyramidals are what you would worry about with lurasidone. It may also be a top choice if patients wish to avoid potential weight gain, so not much effect on the histamine receptor that leads to weight gain. Similar to lurasidone, ziprasidone or Geodon has a pretty relatively mild side effect profile in comparison. However, it does have the highest risk of QTC interval prolongation, and I'll discuss that more in depth in an upcoming slide. Finally, we have risperidone and olanzapine. They have pretty similar side effect profiles, and these two are associated with the highest risk of hyperprolactinemia, which we said earlier can lead to, over time, to infertility or bone mineral density decrease. And of those two, risperidone is slightly higher in risk. So the side effects we most commonly think about with the atypicals being the extrapyramidal side effects. And these are drug-induced movement disorders, so they don't just naturally occur. The four recognized extrapyramidal symptoms, so pseudo-Parkinsonism, just what it sounds like. Patients look as though they have Parkinson's disease, so they'll have a shuffling gait, tremor at rest, or that kind of pill rolling motion of their hands. Akathisia, which is kind of a restlessness, similar almost to restless leg syndrome. The patient feels like they just have to move their legs, almost like something crawling on their legs. Acute dystonia, which is defined facial grimacing, their eyes kind of roll up in their head, muscle spasms of the face, even laryngeal spasms. And then kind of the classic extrapyramidal side effect, we have tardive dyskinesia, which is an effect usually on the tongue, so the patient kind of sticks their tongue out, rolls it a little bit, brings it back in, and that's completely involuntary. As far as the time frame of when to look for these reactions, acute dystonia being acute, it can occur up to 5 days, and it can even occur within hours of the dose. Parkinsonism and akathisia usually occur within 5 days up to about 2 months. And then tardive dyskinesia is more of a long-term effect, so it usually doesn't occur for months, but it can occur up to years after. I'll talk a little bit about QTC prolongation, which is a pretty common side effect of the drugs. The QT interval represents depolarization and repolarization of the ventricles of the heart. Some antipsychotics prolong the interval more than others, which we'll see on the next slide, and this delays repolarization of the ventricle and increases the risk for torsades, which is a potentially fatal form of ventricular tachycardia. As far as how much the drugs increase the interval, as we'll see coming up, some are worse than others, but an increase of less than 5 is thought to be insignificant. Some drugs have been removed from the market for QTC increases between 5 and 10, so typically an increase of about 10 milliseconds is considered to be clinically significant. And this effect is amplified if the patient has other risk factors for QTC prolongation, so patients with structural heart disease, hypokalemia, if they have a family history of congenital QT prolongation, or if they're on some other drugs that also prolong QT. So prolongation, a typical QT interval is considered prolonged if it's greater than about 450 milliseconds in males or 470 in females. And the arrhythmias are most notably associated with the QTC above 500. And I put on here, if you're not sure how to find the patient's QT interval, you notice that they're on several different QTC prolonging agents. You can find this under the chart review tab, and then under that, go to cardiology, and then there, if they have any EKGs, they'll be listed there. And you can see with the arrow the QTC interval. And then this patient is 468. So in a male patient, this is would be considered prolonged, and in a female, it's right at the cutoff. So in comparing the individual agents for QTC prolongation, the worst for this is ziprasidone. And studies have found that it increases the QT anywhere between 9.6 to up to 15.9 milliseconds, which, like we said, about 10 milliseconds is considered clinically significant. Quetiapine is the next most associated with this, although some studies have not demonstrated any increase in QT, and some up to about 8 milliseconds. So plus or minus there, but it's still considered to prolong the QT. A study of the effects of olanzapine and risperidone, which are the next most severe, found that they have a clinically insignificant effect on the QT, although they still did cause a prolongation of about 1.7 and 3.6 milliseconds. And then several studies and meta-analyses of the newer atypical antipsychotics have demonstrated that aripiprazole actually does not cause QTC prolongation and may in fact shorten the interval. So that's probably a good choice if the patient is on several other QTC prolonging drugs but needs an antipsychotic. This may be the way to go. Lorazepam is also a newer drug. It's likewise not been shown to have any significant effect so far in the QT interval. And then clozapine is in there, really indeterminate. So there's some case reports that have linked clozapine to some cases of torsades. However, that effect seems to be more dose dependent, and these patients were on pretty high doses of clozapine. The incidence is currently listed about less than 1%. So of all of these, definitely ziprasidone has been shown to have the greatest effect. So there's black box warnings for antipsychotics. Our elderly patients with dementia, you commonly hear that antipsychotics should not be used in these patients. For dementia-related psychosis, because several studies demonstrated that these patients actually have an increased risk of death when they take antipsychotics. The most common causes were heart failure, sudden cardiac death, or pneumonia. And this was found to be significant enough that the FDA extended this warning to all first and second generation antipsychotics. The exact mechanism behind the pneumonia incidence is unknown, but some of the theories include the extrapyramidal side effects, such as dyskinesia, which can result in muscle spasms in the pharynx, which could cause the patient to aspirate. So it's not necessarily a bacterial community-acquired pneumonia. It's more of an aspiration-type pneumonia in the elderly. And something interesting, the risk of the death from pneumonia was found to be most significant within the first week of starting the drug, so it seems to kind of wane away with time. Overdose of antipsychotics. An acute overdose was noted to rarely result in serious symptoms, but it is definitely possible. So symptoms range from a mild intoxication of sedation and hypotension, which are just kind of extensions of the drug's effect, all the way up to severe intoxication, so that acute dystonia. The patient can seize, arrhythmias, and then they can eventually be comatose. Management of the overdose, supportive care, again, oftentimes this isn't super severe. Gastric lavage, activated charcoal, and if the patient has any arrhythmias from the overdose, phenytoin or bicarb can be used. Some overdoses, they force the patient to vomit. Emesis, in this case, is found to be pretty ineffective, as antipsychotics have kind of an antiemetic effect already, so your reflex to vomit is already suppressed. Drug interactions. Smoking is a notable association with clozapine, and this is significant because several studies have noticed that a vast majority of schizophrenic patients are also smokers, so up to 60% of schizophrenics actually smoke as well. So in a patient on clozapine, this is a pretty significant interaction and can increase clozapine clearance by up to like 55%. Heavy smokers, when they come to the hospital and they're hopefully not allowed to smoke while they're here, can experience a rebound increase in the clozapine concentration while they're here. This has the potential to cause the patient to seize. Of note, in trying to mediate this, there were some studies that logically thought maybe a nicotine patch could help with this, but the reaction is noted not to have anything to do with the nicotine component, so this wouldn't have any effect. Additionally, fluoroquinolones are 1A2 inhibitors, so they can increase the concentration of clozapine as well, or olanzapine. Another drug interaction that we get often from verifying orders, it'll flag antipsychotics with SSRIs. So when is this significant enough to warrant a change? And that comes from activity at the serotonin 2A receptor, like we mentioned earlier. And this activation of excess serotonin leads to a decrease in dopamine. So it's an additive effect with dopamine. So the combo increases your risk of those extrapyramidal symptoms. And self-assessment question, so which of the following antipsychotic agents is associated with the greatest risk of hyperprolactinemia? And the answer here, so of the choices given, as we saw in the comparison table earlier, olanzapine and risperidone are noted to have the highest risk of hyperprolactinemia, but of these two, risperidone has the higher risk. So that was some background, just pharmacology and indications for antipsychotics. So some trends in inpatient use and how pharmacists can optimize usage of antipsychotics. So in 2013, there was a pretty large retrospective study that evaluated antipsychotic use in just over 30,000 adult admissions by the Department of Health and Human Services. And their exclusion criteria, they excluded any OB patients or psych patients. They excluded patients that had a primary or a secondary diagnosis of a psychotic disorder. Those patients were obviously more likely to already be on an antipsychotic. And they excluded patients who were missing a home med list. Of these patients, they included just over 17,000 patients with a median age of 64. Of these 17,000 patients, they found over 1,500 that were charged for an antipsychotic during their admission. Just over half of these charges were new initiation for the patient, meaning the patient was not on an antipsychotic before they came to the hospital. 26% of these admissions for any indication were discharged on an antipsychotic, having not been on the medication before they came, so these were new starts and the patient was then discharged on the medication. And then 16% of exposures were thought to be at least one dose that was potentially excessive, which is that criteria and dose was set by CMS. So this table describes antipsychotic exposures from the study that had at least one day of a potentially excessive dose, and again that was defined by Medicaid. You can see in the table that atypicals were used nearly 3 times as often as typicals, so 2.8% versus 7.2%. Of the atypical antipsychotics, the most frequently dosed greater than 150%, which is what they defined as excessive. The most of the atypicals, was risperidone. So if you look at the table, 7.5% of patients who were given risperidone were potentially given a dose that would have been greater than 5 milligrams. You can see the max daily dose recommended was risperidone, 2 milligrams. And then of the typical antipsychotics, that was haloperidol. 11.3% of those patients received a potentially excessive dose. Here you can see that the study also determined several patient characteristics that were found to be associated with initiation of a new antipsychotic inpatient. And again, that means that the patient wasn't taking the medication outpatient. This was a new start in the hospital. You can see the male patients and patients who were above 75 years of age were more likely to have been initiated on an antipsychotic, as were the patients with delirium, dementia, or who were mechanically ventilated. And these patients were more than twice as likely to get an antipsychotic. In this table, we can see some additional factors that were associated with hospital discharge on a newly initiated antipsychotic. So the patients who were started on an atypical antipsychotic were more likely to be discharged on the medication if they were, again, age 75 or older, if they were discharged to a location other than home, so a nursing home, inpatient rehab, or if they were on an atypical. So atypicals were more likely to be continued at discharge than typicals. Summary: in this cohort of non-psychiatric patient admissions, antipsychotics were used in up to 9% of admissions, more than half of which were new starts for the patient. 16% again were potentially excessive, and the most important statistic from the study, 26% of these new starts were continued at discharge. I'd also like to bring in guidelines from the critical care community. So the previous study brings up a good question: when we're starting all these new antipsychotics, when in the patient's admission are we starting them? So some are started in the ICU to treat ICU delirium. Although the Society of Critical Care Medicine's guidelines for pain, agitation, and delirium note that these are potentially ineffective. So their recommendations are to not use haloperidol or an atypical antipsychotic to prevent delirium or to treat delirium. Although they do state they should be used short-term if they're warranted, but they make special notice to discontinue them immediately after the distressful symptoms are resolved. Here I have just an example of failure to discontinue an antipsychotic that was intended to be used in the short term. So this patient was prescribed quetiapine 50 milligrams nightly for ICU delirium during a previous admission on May the 24th. The medication, as you can see, was continued in the discharge orders. And then the patient was readmitted a few weeks later. And the patient was, of course, on their home med list because they were discharged with the previous admission. So when they came to the ER in the subsequent admission, it was continued. And you can see they received several doses inpatient before the medication was discontinued, as it was intended for short-term use in the ICU, but was just never reconciled and stopped. So here we have another patient case. So patient is a 46-year-old female that was discharged to the floor from the ICU after a 13-day stay, during which time she developed significant delirium and was treated with quetiapine 100 milligrams BID. At this point, she's been extubated for over a week, fully alert and oriented, no longer delirious. The next day, while reviewing her medication profile, you notice she still has orders for the scheduled quetiapine, but it's not on her home med list. So what could be a good course of action for this patient? One course of action, you could contact the physician, whoever's taking care of the patient, and just inquire whether they're still delirious, whether they still need continued antipsychotic treatment. And then recall the study that I summarized in the previous slides, which found that among nearly 18,000 patients who were studied, about 1 in 10 received an antipsychotic admission, and over half of those were new starts, and then about a quarter of those were continued at discharge. And so this intervention could potentially prevent excessive doses of a potentially unnecessary medication. Take just a second to talk about one specific medication, clozapine, since it is a little more complicated to manage than the other atypical antipsychotics. Clozapine does have a REMS program required by the FDA due to its association with agranulocytosis and severe neutropenia, which can lead to fatal infections. So we are required to report the patient's absolute neutrophil count to the FDA. And their slogan is no blood, no drug, so the level monitoring is required to continue to dispense the drug to the patient. Here I just included our policy for clozapine. So when we receive an order for clozapine in the pharmacy, Policy states place it on the patient's profile and send the medication, and then the protocol to order a baseline CBC with differential if it's not already ordered. And then the patient will be reviewed daily, and when CBCs are drawn weekly in the initial period, those will be called into the REMS program. We do have a clozapine order set, which I included here in case you ever need to assist with order entry. So a site consult is included with the order set, as well as the pharmacy consult order for REMS enrollment. The weekly CBC is included, so if clozapine is ordered through the order set, the CBC should already be ordered for you, and then, of course, the drug itself. And a potential pretty big use for antipsychotics in patient acute agitation. So haloperidol has historically been used in the treatment of acute agitation, although up to 20% of patients are noted to experience extrapyramidal side effects and catatonia with haloperidol. It's noted that when combined with a benzo, such as lorazepam, this incidence is cut down to 6%. And likewise, you could inject with diphenhydramine or promethazine as well. Second generation antipsychotics may now be preferred in the acute setting, as we'll go over, since they have lower rates of extrapyramidal effects and are demonstrated to be just as effective. According to a consensus statement from the American Association for Emergency Psychiatry, the following PO and IM doses are considered to be equivalent. So PO risperidone plus lorazepam is just as efficacious as it is given IM. PO olanzapine is just as efficacious as risperidone, which we'll talk about a little more in the upcoming slides. And then PO risperidone alone is just as efficacious as haloperidol. So if the patient is able to take PO, there are selections out there that are just as effective as they are given IM. The statement also makes recommendations for treating acutely agitated patients who have a known psychiatric illness. So notice again that the PO options are recommended first before the IM. However, when the PO is preferred, it may or may not be a viable option depending on the patient's level of cooperation, whether they're combative or a threat to themselves or staff. So here we can have kind of an algorithm. So start off with a PO second generation. Again, PO preferred, second generation preferred. So risperidone or olanzapine. And then you get to the IM options, again, olanzapine or intramuscular ziprasidone. For acutely agitated patients without a known psychiatric illness, the recommendations are separated based on whether or not agitation is a result of intoxication. So if it's associated with intoxication due to a CNS stimulant, such as meth or cocaine, then benzodiazepines are recommended in these guidelines. If it's due to a CNS depressant, such as alcohol, there's a role for haloperidol, antipsychotic. Again, preferably PO first if the patient is cooperative and not too agitated. Delirium patients for whom alcohol or benzo withdrawal is not suspected, atypical antipsychotics are again preferred. So selection, we have several options for parenteral antipsychotics. Is one preferred over the other? Are they all equally effective? So to compare some of these individual agents, we can look back at a large meta-analysis of 7 randomized controlled trials, which included patients with agitation that was severe enough to warrant parenteral therapy. One of the studies included in the analysis studied 270 acutely agitated schizophrenic patients, and their endpoint was a greater than 40% reduction in this agitation scale at 2 hours post-injection. They found that 80% of these patients achieved this endpoint with olanzapine versus 60% with haloperidol. In addition to this finding, you can see the adverse events here at the bottom table, and you can see that the incidence of adverse effects, which are extrapyramidal effects, are much higher in the haloperidol group compared to the olanzapine group. A second study in a meta-analysis included 201 patients with bipolar disorder, and their comparison was of olanzapine versus lorazepam versus placebo. And they found that 26% of olanzapine patients required an additional injection versus 53% each with lorazepam and the placebo, so almost double required an additional injection as it wasn't as effective. Slide. So in conclusion, for the meta-analysis, within 2 hours of administration, intramuscular olanzapine was superior to placebo in all populations. There's no difference in efficacy between olanzapine and haloperidol or lorazepam given IM. And IM olanzapine, in comparison to haloperidol, causes less dystonia, less Parkinsonism, less akathisia. An additional study of 737 patients analyzed adults who were treated for acute agitation in the emergency department. And their comparison was olanzapine versus ziprasidone versus haloperidol versus midazolam. Their efficacy endpoint here was the proportion of patients at 15 minutes who were considered to be adequately sedated from the injection. Here in the top table, you can see that both olanzapine and ziprasidone resulted in a greater proportion of adequately sedated patients at the 15-minute interval as compared to haloperidol, even up to doses of 10 milligrams. Olanzapine and ziprasidone were not found to be any statistically significantly different. In the bottom table, we can see time to adequate sedation, and that's compared to the reference of about 12 minutes with midazolam. And what they found was that only olanzapine demonstrated no significant difference from the reference midazolam, while ziprasidone and both doses of haloperidol resulted in a longer time to adequate sedation. So conclusions from this study, midazolam resulted in more rapid sedation, but they found that these patients, while they were more quickly sedated, they also required more rescue sedation. Olanzapine appeared to be more effective than haloperidol and had significantly less risk of those extrapyramidal adverse effects. And then finally, ziprasidone may be less preferred than olanzapine due to its higher potential to cause arrhythmias and its delayed reconstitution. And finally, a patient case. So we have a patient, 36-year-old male. He arrives to the ED. He's acutely agitated. He's taken to a room. He gets even more agitated, attempts to attack the nurse. He has a history of schizoaffective disorder. He's not on any medications at home. Socially, he doesn't use any alcohol or smoking. So for this patient, which of the following would be potentially the most effective treatment for the patient? So note that the first line treatment for acute agitation not due to intoxication should be the oral antipsychotic. However, this particular patient is a danger to the staff, so the IM agent is more appropriate. And then, like we mentioned in the meta-analysis and several studies, evidence shows that IM olanzapine is more effective for acute agitation than is IM haloperidol. So in summary, antipsychotic agents are used in the inpatient setting for multiple indications, many of which, as we saw, were off-label. Monitoring is important for extrapyramidal side effects, orthostasis, metabolic changes, and for clozapine in particular, monitoring the CBC absolute neutrophil count. Pharmacists can prevent patient harm by recommending discontinuation of antipsychotics at patient discharge from the hospital, or even just step down from ICU level care if appropriate. And finally, in the setting of acute agitation, olanzapine is likely more effective as compared to haloperidol, which is the traditionally used agent, and is additionally associated with less adverse events, particularly the extrapyramidals. And that's it. questions, comments, concerns? Brittany. I didn't come across a particular, the question was when the patient leaves the ICU, if you're going to stop the antipsychotic, would you just abruptly stop, or would you taper, reduce the dose in some regimen? I didn't come across a particular tapering regimen. I think it depends on, was it a scheduled treatment that they were on for several weeks while they were ventilated or agitated, delirious, or was it just a PRN because they were delirious? It was on the profile. They only got like 2-3 doses, a dose every other day. So I think it's patient specific. I think the majority seem to be kind of PRN delirium. So I think if they were just PRN, I think abrupt discontinuation would be fine. If it was something scheduled, they're getting, twice a day, around the clock, regularly, never missed a dose. Like I said, I didn't come across a particular regimen, but maybe discontinuing after you cut the dose in half, maybe. If it's BID, maybe go to once a day for a few days, see how they tolerate it, and then cut it off. Cassie. So the question was, an acutely and agitated dementia patient in the ICU, they need something for delirium. What would you use? Would you still use an antipsychotic? I think different options, maybe even diphenhydramine, something like that, if they need to be sedated. But I think an antipsychotic would be fine in the acute period. It was more kind of longer term. I just wouldn't, if they weren't on it before they got here, I'd just make sure that when they left, they weren't still on it in a longer term use. But, yeah. Up to the hospital. So there was kind of a dosing recommendation if they are smokers. So they recommended you could decrease the dose by, I think it was 10%. They recommended a total of, I think it was a 40% reduction. So if they are a frequent smoker, they recommended 10%, cut it by 10% daily until you get to the 40% mark. If they're not going outside to smoke, they're smoking in the stairwell or in the room.